Welcome to the review of Module 9, which is the neural drugs. Okay, now we're going to talk about Alzheimer's disease. And one of the things that you need to know is that we want to improve symptoms and reverse cognitive decline, but our drugs right now cannot do this. So about the only thing that we can do is to slow the loss of memory and cognition and prolong independent function. But these drugs only work for about 1 to 2 years, and they don't work in the majority of people. So for the 4 drugs for Alzheimer's dementia, you need to look up the dosage and frequency of these drugs and how long are they taken. What are the indications for stopping? These are the cholinesterase inhibitors. I've kind of marked what you need to know on here. One of the things you need to know is what degree of dementia they're used for. So you need to be specific about that. You need to note the time intervals for increasing the dose on donepezil. Note that the mild for rivastigmine, I should say, the severe indication is only for transdermal. You need to know the cholinesterase inhibitor side effects. So in the lecture, I did describe what the cholinergic side effects were, so you need to review those. Notice under toxicity, it talks about all these adverse effects with hallucinations and things. So what would you do about hallucinations? If it's a toxic side effect, what would you do? The NMDA inhibitors, again, note the severity of the Alzheimer's disease that it treats. Know its indication. We usually do give it, I should say, in combination, but can be given as monotherapy. And so you need to know on this one when to add the second drug. What do you do for somebody who has renal disease if it's 100% renally excreted? Now we're on to Parkinson's disease. You need to know when to use each drug. So with the MAOBs up here, they can be used primary, first line, if there's mild symptoms. If there's more severe, especially motor symptoms, you need to use the levodopa. But again, the benefit of that is that you do have better symptom control, but long term they develop the disabling dyskinesias. Okay, so for levodopa, why is it given in combination with carbidopa? You need to know that answer. That if they are treated with levodopa and there is no improvement, you need to definitely question the diagnosis. Note that it takes several months for full therapeutic effect. We do have some dietary implications of this well. But the levodopa, again, it's a shorter term drug that the symptoms are well controlled for 2 years, but then by the end of 5 years, it's not effective anymore. That's one of the reasons why we try to delay its use. Wearing off. You need to know these 3 things that can be done to minimize wearing off. So obviously shorting the dosage intervals so that there's no wearing off. or giving a drug that prolongs its half-life. And look at the encatapone. Know what class of drug it is and how that class works. And or give a direct-acting dopamine agonist. And you need to know which drugs are dopamine agonists. Dyskinesias. These are the things that can be done to manage dyskinesias. There's 3 of them. Reduce the dosage of levodopa is 1. Amantadine or dopamine agonist. Why would these help? And we obviously know what amantadine is, but which drugs are dopamine agonists? And then there are other things that can be used with surgery and electrical stimulation, but we don't really talk about that too much for pharmacology. The dopamine agonists. Note the uses again, that it can be used as this progresses. So it can be used alone in the early part or advancing. So we like to use this first line in younger patients because remember, levodopa doesn't last forever, so we like to use something else instead of levodopa. It can be added to levodopa also. Its adverse effects. There's a couple of drugs that have this last adverse effect with the gambling, other compulsive self-rewarding behaviors, sexual problems, shopping. But look at that strange one and know what other drug has the same effect. And by the way, that is relatively rare. I have not seen it. Okay, so this is ropinirole, which is Requip, and another dopamine agonist. Look at the side effects of this one. That's why I have it highlighted. What would you do if they develop these side effects? And that the answer to that question is kind of on this slide and another slide. And I don't know if that's next or not. No, it's not next. Here are some of the MAOBs. You need to know its action. Note the indication on this. This is mild impairment and bradykinesia, so slow movements as the main symptom. It's also used first-line therapy for postural instability and or gait impairment. The benztropines or cogentin, this is one that we use more for some of the to control some of the other unwanted effects of Parkinson's disease. Note the indication on this one also. Okay, the amantadine. This isn't a first-line agent, but this is one where you can combine it with levodopa for dyskinesias. I think it's interesting that this was an antiviral agent. Okay, so an overall on Parkinson's. Consider how the side effects can be used as an advantage or treatment option of the different classes. Which drug combinations are useful? What to do with some of the side effects? Why drugs are given in combo? What are we trying to do with that? You need to know the indications of classes according to symptoms and the actions of the treatment classes. Now we're moving on to anti-epileptic drugs. Um, I don't ask about the various type of seizures and what meds were indicated for them. So I don't say which one is recommended for a tonic-clonic type seizure. I don't ask that. You need to know the general purpose of the anti-epileptic drugs. So the idea is to eliminate seizures, but that usually isn't possible. Um, I should say it's often not possible. Look at the withdrawal effects of baclofen if it's withdrawn suddenly. And I also already said that about the bottom. Oh, phenytoin. You need to know which drugs need laboratory monitoring and why do they need laboratory monitoring. These are drugs with narrow therapeutic indices. With phenytoin, there's a lot you need to know about it. I've highlighted some of the more prominent items, like the gingival hyperplasia and hirsutism, and what you can do to treat that. The phenytoin, there are so many drug interactions. You need to be aware of those. It needs to be administered with food. With the Tegretol, again, you don't need to know the seizure types. Need to know, you do need to know it's one of them that requires laboratory monitoring. And one of the interesting things on this one is it induces its own metabolism. So levels may decrease over the first month of use. Valproic acid is another one that needs laboratory monitoring. You do not need to memorize what the therapeutic levels are. I wouldn't know them. But that they may have tremors if the levels are higher, even though it's in the normal range. Hepatotoxicity with valproic acid. What are the signs and symptoms of liver failure? Again, this one needs to be taken with food. Lots of drug interactions. Now we're moving on to muscle relaxants. You need to know what are the indications of each of the muscle relaxants, which are used for spasticity and which are used for as a general muscle relaxant. What is the withdrawal syndrome for baclofen? That it needs to be renally dosed. So baclofen's the first choice for spasticity. I already said note the side effects of it, and again what happens with abrupt withdrawal, so look that up. Dantrolene, again look at its uses. One of the interesting ones on this one is the malignant hyperthermia, which is a possible fatal condition that's caused by succinylcholine, which is a paralytic agent that's used in anesthesia and a general anesthetic. It also causes hepatotoxicity, so many of them do. This one can cause, this one can be a little bit more severe and may be fatal. This one too, the Xanaflex, is hepatotoxic. With Flexeril, because this is most commonly prescribed for musculoskeletal problems. This one does not need monitoring, but it should not be used in severe hepatic disease. It does have more dry mouth, but dizziness is less frequent. This is one you do need to know because it's prescribed frequently. Scalaxin, this is one of my favorite ones because there's less drowsiness with it, but it still needs monitoring if they have liver problems or renal impairment. And then ADHD. This is the only slide I have on this. I think there are 4 potential questions. Compare the short-acting and long-acting stimulants. What's the benefits of those? I would compare the stimulants and the non-stimulants. There's an entire slide on how to treat the stimulant side effects. Note the potential for abuse of the stimulants and who is most at risk, or be able to identify who is most at risk. And note the indications and side effects for the non-stimulants. Okay, so next week is the test. On to the test.